other physicians that speak very highly of it. So it very much caught my eye to see if I could come back.
Good. Well, we're so glad that you're here and welcome home. So let's get to it. COVID is still with us. It seems to be waning a little bit,
Yes.
but that's what we thought about the first surge with the Alpha variant. Let's unpack the real name of COVID, and it's SARS-CoV-2
Correct.
coronavirus novel, or what does that name mean?
So novel means that our bodies have not been exposed to it before. It's a new variant, it's a new virus, whereas the original SARS virus back in the early 2000s is kind of this one's cousin. It's not similar to, they've got some similarities there, but it's a new variant, it's a new strain, it's a new virus. And so hence the novel in the name, it's new.
Okay. And the impact for us and our immune systems would be what?
We haven't seen it before. So it's entirely new. Back when it came out, in November of 2019, it was completely new. Our bodies, nobody knew how we were going to respond to it. We're still trying to figure out how some people respond to it. There's a lot of unknowns there. And so if everything is novel, comes a lot of data, comes a lot of progress, comes a lot of pitfalls too.
Sure.
So.
Okay. So this is a new virus, and I recall back in the early 2000s, we were looking at H1N1 influenza that was going to be a novel virus for our generation.
Yes.
It was around in 1918 for the Spanish influenza pandemic, and we prepared for that. It seems like this is very different. Is it the contagiousness of this virus or this variant?
So there's a lot of factors into that. It's very contagious, especially the Delta variant is extremely contagious. It's more than other viruses we've seen in the past, other common viruses that we've seen. There's a lot to it with that. And so it's very difficult to pin everything on the variants. So we're still trying to figure out a lot there.
Okay. The research will be very interesting as it plays out over time, and we have a moment to catch our breath and look back at the data.
It's spread so fast, and that's something that's different with especially the Delta, but even the Alpha variant was spread so much faster than we've seen with other viruses. And plus, in 1918, planes, trains, automobiles, travel is a lot more easy in 2019 than it was back in 1918. So things spread a lot faster. But even in some of the other pandemics we've seen in the late 50s with one of the flus, and then 1969 flu, same thing. Travel was more accessible, but the severity of the illness wasn't there, and the contagiousness wasn't there either with those strains.
Sure. And we didn't have antiviral vaccines in 1918 and 1950.
Not the same way we do now.
Right. So let's talk about the vaccines. One of the things that everybody seems to be saying, at least who is a physician or healthcare worker, is get the vaccine, get the vaccine. Are there some patients, some people, some of our friends or family who should not get the vaccine?
So if you look at the CDC recommendations, the real only true contraindications on the site state that if you've had a severe reaction to one of the mRNA vaccines in the past, maybe you should not get the second one or another dose. These are new, right? These are novel vaccines that we're using. So that eliminates a lot of the population. However, I understand a lot of the hesitancy to get these vaccines in certain people who are immunocompromised, who've had severe reactions in the past to flu vaccines.
If I may interrupt, when you say immunocompromised, is that just somebody who is on chemotherapy for cancer treatment, or what would that person be like?
So immunocompromised just means your immune system is not functioning as well as it could, or somebody who has no conditions whatsoever. And so yeah, absolutely, it could be somebody who's on chemotherapy, but there's a lot of other disorders, myelodysplasia, where your blood, you don't produce many red cells or white cells. Those are people that can be immunocompromised too. People that are on steroids chronically for different diseases, rheumatoid arthritis or whatnot, those people are also considered immunocompromised, even though they have the right amount of white cells to fight infections, and they're not on chemo. They're still technically immunocompromised, as well as people with dialysis to a certain extent, people with liver disease. They're all immunocompromised.
So is it because they won't form antibodies against this against the coronavirus with the vaccine, or is it that the vaccine will cause distress for them?
I don't think the vaccine would cause distress for them. I haven't seen that. I've actually seen people who are immunocompromised do better with the vaccine in terms of reaction to a vaccine. But being able to produce antibodies is a patient-by-patient issue, which is why the boosters were rolled out for these immunocompromised, these people who don't have these very active immune systems. That's why that booster recommendation was rolled out in the past few weeks. Was because of that, because they may be able to produce some antibodies, but not to the level of someone who has, a normally functioning immune system. So yes, they may be able to form these antibodies, but that may not convey immunity.
Sure. So you may have had the vaccine, but not the protection from
Exactly.
I have two patients that have had a syndrome called Guillain-Barre Syndrome, and it's a nerve disease that comes from the inflammation related to a viral illness or a viral vaccine, and that can be very, very scary. It can
Absolutely.
be at its most serious. People can be paralyzed.
Yeah.
So I know that's one of the concerns with this vaccine. Are there any other serious issues that a patient would want to be sure to talk with their physician or nurse practitioner or PA about?
If you've had severe reactions in the past to influenza vaccines or some of the other viral vaccines like the Shingrix or shingles vaccine, that's certainly a concern that you should talk to your physician about and see what they think about it, because people do have serious reactions to non-COVID vaccines. That's definitely a thing. You can have some brain issues, some demyelinating or some nervous issues from vaccines that are exceptionally rare, but these things happen.
Okay.
It's a known issue with anything. Any medication has side effects. Any vaccine may have side effects as well.
Sure. Okay. In your recommending vaccines, we have three vaccines that are available currently in the United States: the Pfizer vaccine, the Moderna vaccine, and the Johnson & Johnson. Can you give the highlights about the similarities and differences between those three vaccines: Pfizer, Moderna, Johnson & Johnson?
Absolutely. So we could start with the Johnson & Johnson first, because it's very different than the Moderna or the Pfizer. So the Johnson & Johnson vaccine uses a harmless virus, which is where we create it in a lab that has, we make this virus have no replication abilities whatsoever. But it contains the protein for the spike protein for COVID. And so we inject this dead virus essentially into the body, this harmless virus, and it injects your cells with this genetic material, which is taken up by your cells, and it uses its own cell machinery to process the spike protein. And again, it's a harmless virus. It does not cause any disease. It doesn't cause any issues. After it injects the material, it's destroyed. And then that material gets taken up by your cells. It gets made into a protein, and the protein can only last just a handful of minutes before being destroyed in the body. So there's no long-term effects from any protein that's wandering around. It's then presented to other cells in the body who latch on to the spike protein as sort of a lock and key mechanism. And then that cell in turn tells its other friends, hey, come here, look at this protein. I found it's not like anything that's in our body. And then that's where your antibodies are made from this, okay? And so it's very effective. We've been using these viruses like this for some time for different mechanisms and cancer research and whatnot, but this is somewhat new for the Johnson & Johnson COVID vaccine. The Pfizer and the Moderna are a little different. They actually just inject the mRNA, which is messenger RNA, which is just a genetic sequence. It's a code, again, that take up by your cells and that your host cells, your own immune system, Same thing. It processes this messenger RNA, which only lasts seconds in the body before being denatured or killed. It can't survive out in the open, so it's taken up into the cell. And your own host cells, again, use this own machinery outside of the nucleus, which is where your DNA is held. There's never a manipulation of your DNA. It's tucked nicely inside of this nucleus, which is Fort Knox, right? So it's never manipulated. And then this messenger RNA turns into a protein, which gets presented to other cells in the body. And again, hey, look at me. I'm not like anything else you've seen. And again, it's taken up, it's killed, it's destroyed within a matter of minutes. And then there you get antibodies, which are polyclonal, which means it's many different cell lines can produce this antibody. Okay, so that's where we get our immunity from.
So, so cells that produce antibodies produce a particular type of response, but does it stick around? We've heard that, well, this vaccine doesn't give immunity for a long period of time. How does the body know to say, we've never seen this before, we got to remember that, so that if we see it again, we'll be ready for it? How does that happen? How does that work?
So we have memory B cells and memory T cells, and the B cells are the ones that produce these antibodies, and they have memory. Like they can see and they can say, oh, I've recognized this. I've tasted this flavor of protein before. Let me make some antibodies towards it. And that's whenever you get this response in a couple of days, normally it takes 2 weeks to produce after a first-time exposure. That's why they're at the ready after a day or two. They have antibodies at the ready to combat these infections. And so we do know that the antibodies wane over time. There's several studies that come out over the past few weeks that show we do still have a response after 5 months, but it's not 100%, and it's never 100% with anything regardless. But most of these studies show an average of about 70% effectiveness after 5 months. The lowest study is 40%, but the most of these are in the 70, high 60s or low 80% effectiveness after these 5 months.
And that's a good range?
That is an acceptable range. Again, we're very new at doing some of these vaccines. This is the first time it's been implemented. We've been doing this mRNA since the original SARS virus back in 2000, and it's been kicked around since then. And that's why it's not really a new vaccine. It just never had an issue to roll out. We've never had anything like this that we need to make mass vaccines for and use this technology for. Flu's been around for a very long time. Shingles has been around a very long time. Hepatitis. But now we have this vaccine that needs to be made for a pandemic that hasn't gone away in a year and a half.
Okay. So as I understand it from what you're describing is the Pfizer and Moderna are mRNA virus vaccines. And the technology is we're able to have them code for a particular virus's protein, like the spike proteins from coronavirus. So it seems like our future would be that we would be able to quickly develop a vaccine for another new virus using the same technology. And I'm going to use the term plug and play. So if a new virus is discovered, or there's an anticipated influenza virus that's changed or mutated, is that a way that we can rapidly transition from a pandemic coronavirus to a high incidence influenza virus that's a vaccine that's going to be better?
Absolutely. I feel like there's a lot of potential with this, is that we can sequence viruses very quickly and see what their genetic material is, and we can make these probes that are, again, genetic materials that we can in turn change into a vaccine against this disease. There's a whole lot of application there, and I'm sure that there'll be advances there. In the next several years, we're moving rapidly with this. Whether or not this will be applicable to other viruses is very difficult to say at this time, because not all viruses are the same. Of course, some mutate rapidly, some mutate slowly. So there's a lot of potential there to roll this out in other areas in the future.
Okay. So I want to remind our viewers, if you have any questions, please submit those in the chat or comment section. We'd love to hear from you. Also, Adena Health System and many other areas in our regions are providing you with the coronavirus vaccines. So there are multiple locations. This is at no cost to you. This is a government-funded and sponsored vaccine program. So we would want to be sure that you take advantage of these vaccinations. Also at Adena, at the Packard Medical Education Center, we have a drive-through COVID testing center. If you have symptoms, we can do a rapid test on you and let you know yes or no, COVID or not. Also, if you don't have symptoms, but you may have been exposed or you have other family members, you would have a test that would be back in 2 to 3 days, and we would close that loop with you to let you know about the result. So once again, we strongly encourage you to vaccinate. If you have symptoms, it's important to know, do you have COVID or not, so that you can properly quarantine. All right, we're going to switch gears again into the technology part of this.
Okay.
And one of the treatments for somebody who is positive for coronavirus infection, but is not in the hospital, is something called monoclonal antibodies. Can you talk about, first of all, monoclonal is a big word, and if you could break that down for us and tell us what that means and how this treatment is used in people who are not in the hospital.
Absolutely. So I discussed earlier polyclonal, and this is a good segue into the monoclonal issue. A monoclonal antibody is just derived from one cell line. Okay, that's all that means. It's derived from a single cell. It's basically a single use. You give these antibodies, and then they're preformed antibodies that we can use in an infusion. Pretty effective, pretty safe. There's very few side effects from this infusion. And they go into the body. They neutralize the viruses, similar to antibodies that would be derived from the host. The difference here is, like I said, it's a one-stop. You use this one time. You don't create memories from these antibodies, so you don't have immunity to it from this monoclonal antibody. You may, in turn, produce other antibodies from just having the infection if you're severe enough. But it's a pretty effective method for it. It's not first line. First line is always going to be vaccination because it's the most effective in treatment of or prevention of COVID. But the monoclonal antibodies have a good role, I feel like. There's probably going to be limited supplies here in the next few weeks, months, all over the country. It's about 70% of the monoclonal antibodies are going to just 5 states. So there's might be a limited supply with this. So it's not a silver bullet, but it can help you fight off this infection for long enough to heal yourself.
So it sounds as though this is an immune booster. This is putting in these army warriors to go in and fight the COVID virus in your system that were already made outside of your body.
Yeah, absolutely. So it is effective, but again, it's the one-stop shop. The best thing to do is probably to get vaccinated and make your own antibodies. That way you can remember these in the future. Studies are starting to show that people with these mild symptoms, moderate symptoms that don't get hospitalized, a lot of these individuals actually don't make their own antibodies. Certain studies are saying 15%. I saw one from Israel a couple of days ago that said 60% don't make antibodies if you have mild symptoms. So that's an issue. If people are saying that I don't need vaccinated, I've already had COVID, you may not have antibodies to protect yourself. Even if you do have antibodies, we don't know what level of antibody conveys immunity. The only way to do that is to get vaccinated and to know you have immunity against severe COVID.
Okay, this is you're young in your career. I'm kind of in the sunset of my career a little bit, or at least I know the sun's going to set sometime. This is hopefully once in a career circumstance. How have you thought about this in relationship to your career, or maybe some philosophical things that this has caused you to think about or to adopt?
It's been quite an experience. I was in training, of course, whenever all this happened. So I was training to be an infectious disease physician, learn how to treat blood infections and HIV and everything else whenever this lands on my lap during the middle of it all. So it's taught me a lot of resilience. It's taught me a lot of being humble about science. It's trusting science. It's reading, a lot of reading, a lot of data interpretation. I think I've grown as a scientist and grown as a physician from being in a pandemic in a field where nobody knew anything at first. We had no idea. I remember whenever we had the first cases in Tampa that I remember my first case walking into the room in my full garb and, nervous to death about how to put on the gowns and the masks and take off the gowns and the mask. It's taught me a lot. I've grown a lot in that. And in turn, it's, I'm hoping to bring that here to Adena to say, got experience of firsthand of leading in a pandemic where the fellows and the program knew as much as the attendings who've been practicing for 40 years. So it's a lot of resilience.
So the impact of vaccinations on chronic, usually childhood diseases. I've never seen a case of measles. I've never seen a case of tetanus. I've seen a few cases of Haemophilus influenza B, deep infections in children, but that's been 20 years. And one of the things that we see down the road from vaccination programs is the benefit. So I think with the COVID vaccine, we're right in the middle of it, and we don't have that perspective or time away from the actual pandemic to say, okay, how does this look? What's the end result of all of this? And that will come with time, and we'll be retrospective in our examination of it. Let's cover some misconceptions before we finish today.
Absolutely.
Especially as we are encouraging younger people to get vaccinated. What do you know about the impact on fertility in young women by any of these vaccines?
There's been several studies that have shown no difference in spontaneous abortions with the background.
Also known as a miscarriage.
Miscarriage, right? Absolutely.
Okay.
So there's no effect on miscarriage whatsoever. There's been several large studies. The rate of the background rate, meaning just normal rate, is about 11, 12, 15% in that range. The studies have shown that, it's about 12% within the spontaneous abortion or miscarriage rate within these vaccine groups. So there's no statistical difference. It fits right in there as a normal rate. And the same with males with sperm production. There's no statistical difference whatsoever. And there's actually studies that show that you may actually produce less sperm with getting COVID rather than the vaccines themselves. So definitely busted.
Okay. How would ivermectin help treat COVID?
That's a great question. It doesn't. There's been several large studies again, and there was a meta-analysis, which is the highest level of evidence we have as physicians. We look at from all the way from case reports, which is the lowest level of evidence, up to meta-analyses, where they take into consideration large studies that have had essentially groundbreaking evidence. And the studies show that it actually does not help, and it actually does increase mortality. There's still ongoing studies about this. It may have a role in certain patient populations when maybe they're less sick or more sick. But as of now, the data does not show that there's any evidence to give it, and it actually may do harm. And as physicians, first is do no harm.
Right.
So right now, there's nothing to give for ivermectin.
Okay. And hydroxychloroquine, that was the hot topic at the beginning of this, and former President Trump recommended it. What about hydroxychloroquine? It's been probably looked at the most during this COVID time. What do you know about that?
Same thing. The same meta-analysis was released about 3 months after or 3 months before the ivermectin. So again, it showed that there's no benefit to it. There's no harm, but again, there's no benefit to it. I was involved in the early projects of hydroxychloroquine back in, whenever it was first getting rolled out. There's no benefit of it in COVID at this time.
Okay. So we do have a question from one of our viewers. That's a very good question. People who are vaccinated are still getting COVID. Why should I get the vaccine? That's a great question.
Great question, and that's probably the most common question, because we know breakthrough infections occur. No vaccine is 100%. Even tetanus, diphtheria, pertussis, pertussis still happens even though you get the vaccine. The issue is that it's probably going to save you from getting in the hospital, and that's why I think people should get the vaccine, is because it's going to maybe save your life. Yeah, you still might get COVID, but you might just have sniffles, fever for a day or two. You still get the loss of taste or smell, which is very annoying, but you're not going to wind up and seeing me in the hospital for some of these treatments, because there's 99% plus of people that are dying from COVID in the US right now are unvaccinated, and the numbers do not lie. Okay. So that is why.
Okay, that's a great question. So if I've been vaccinated, do I still need to wear a mask? Do I still need to socially distance? Can you provide some clarity there?
I think it's always a matter of safety, and we try to maximize the holes that in your life that COVID could get into, like the Swiss cheese model, right? Swiss cheese has holes in it, and you line up these layers, and so eventually, after these big holes get a lot smaller, that there's only a few ways that COVID can get into your life. If you're vaccinated, if you socially distance, if you wear a mask, proper hand washing, hygiene, outdoor gatherings rather than indoor gatherings. If you maximize that, your chances of getting COVID are a lot smaller than if no masking. Studies don't lie. I mean, there's a lot of studies that show that masking does help and reduce the amount of transmission of particles.
So it helps, but it's not foolproof.
There's nothing like that is foolproof.
Okay.
Death and taxes. But wearing a mask will help your chances of not getting COVID.
So what I heard from that list is this. There are many things that you can do to help keep yourself safe. Wearing a mask is one. Washing your hands is another. Staying away from other folks if you have symptoms. And then the objective is to combine all of those protective things into an umbrella of protection. You still get wet when it rains,
yes,
but you're not going to get soaked.
Perfect example.
Okay, so folks, please, if you're unable to receive the vaccine or you have concerns, please wear your mask, wash your hands, keep your distance, get plenty of rest, do all of the things that your mother told you to do when you were a kid to stay healthy. And we hope that at the end of this pandemic, we can come back and say, we're ready for the next one, but this is what we've learned. All right. We don't have any other questions, and I'd like to thank Dr. Cody Horn from Infectious Disease at Adena Health System for joining us today.
It's my pleasure.
Cody was born and raised in Ross County and came back home to practice and help his friends and neighbors. So we're so glad that you're back home and that your family is settled in, and we wish you a long and prosperous career.
Absolutely. Thank you.
So join us next week, or in 2 weeks, for our next edition of Living Well with Adena. I'm Dr. John Gabus, Medical Director of Community Partnerships. Have a wonderful day.